Hey nurses, looking for exclusive discounts? Nurse.org has you covered with deals on everything. Save big on the essentials you need to excel in your career. Don't miss out. Visit nurse.org/discounts for the latest discounts made just for you. You're listening to Nurse Converse, presented by Nurse.org, a collaborative podcast amplifying diverse nurse voices. Get ready for a dose of inspiration, a sprinkle of education, and a whole lot of community.
It's such an honor that you guys voted me to be on here. And I am beyond excited to have my very first guest today, which is somebody who is very near and dear to my heart, Sharon Hansen. Sharon is actually the very first nurse educator that I had straight out of nursing school. I was a nurse for about 5 minutes, and Sharon came into my life and has been a huge influence. She's been a nurse for almost 38 years. So I wanted to bring Sharon on today to talk about some really tough topics and some really topics that are near and dear to, I believe, every nurse's heart out there. And I am so excited to have you on, Sharon. Thank you so much for being here today. Sharon, 38 years, almost 38 years as a nurse. And
Right.
you are, you deserve an award. And I want to add
Right.
to that, guys, that Sharon is actually bedside, still has gone all around, but has found herself back at the bedside for nursing.
Yeah.
And what an
Night shift.
accomplishment, night shift bedside nursing here. So if you're driving or you're just sitting around, I feel like we need to give Sharon a quick hand of applause on that one. So Sharon, I want to just hop in and kind of let everybody know why we decided to get together and do this podcast. And it was, Sharon has a passion for nursing. She has a passion for nurses. I do as well. And we had talked about the vulnerability that comes in nursing, the tough times, the humanity that comes in nursing that I don't think we address enough in nursing today. I don't think that we address the struggles that nurses face outside of the hero term that we so lovely got during COVID, that we're human. And we deal with a lot of things in our profession. And knowing from what I know 10 years ago when I met you and watching you as your career and finding your story, I believe that you have a lot to teach us about what it's like to have trials and errors and adversity and be vulnerable in nursing. So let's dive into that. But I want to start, let's start with asking, how did you get started in nursing? And tell us, everybody hears about that dreaded first year.
Right.
Tell us a little bit about that.
So I planned on being a forest ranger. That was my, and I was backpacking in high school, and they were laying off forestry folks. And I thought, I'm toast. I have no idea what I'm going to do. And my one of my family members said you could be a secretary. I thought I'd be fired in a hot minute as a secretary. So I felt kind of at loss. And then I came across a book. It was written by an ICU nurse telling her story. And I thought, I could totally do that. And then I was, that I just kind of set my course there, and got moved from Minnesota out to Washington State, went to Pacific Lutheran University. Amazingly, in my mind, it was like, oh my gosh, I got into nursing school, and it was grueling and amazing and wonderful. And came out. I always wanted to be a pediatric nurse, but we each have our own insecurities. And I was offered a job where I precepted. It was an adult ICU. And I thought, I should take this because I don't know if anybody else would hire me. And so I did. And I started out there. It was a small hospital. It had a little, I think, 8-bed, 6-bed, 6 rooms, 8-bed unit. 6 of the beds were ICU, and then they had this little telemetry room. And I started out, and it was terrifying. I had this amazing charge nurse on night shift, Betty, and she was my right-hand person. And then 2 months into it, she moved. And it was me as a completely naive 21-year-old with absolutely no clue what I was doing. It was me and agency nurses. And I
Not
was
too different from a
terrified.
setup a lot in today's hospitals.
I was terrified. I had no idea what I was doing. Um, and then there were two agency nurses who felt pity on me, and Ron and oh my gosh, I'm blanking on her. I'm so sorry. Ron, and then this other nurse, it will come back to me, who literally they signed up to work with me on my shifts so that I wouldn't be alone. And they were really experienced. They worked up in Seattle, and they taught me so much. So
Oh, that's
so that yeah, yeah.
what would you
They
say in that first year when you were going through it, so that some of our new nurses out there, what do you think was the toughest part of your first year in nursing? And mind you, this is almost 38 years
mhm.
ago, and we do face some new challenges, especially post-COVID. But give us an idea of what you think was one of the toughest challenges that nurses now are facing in that first year.
um I think not knowing what I needed to know. And the challenge is you go through nursing school and it's very broad. It has to be really, really broad. It's not focused. And I did get to take some coursework, and some of the nurses who taught that actually became my mentors through the years. Like Carol Jacobson. I mean, amazing to be able to learn from her. But I didn't know what I didn't know. And there were so many times where I was like, oh, I'm never going to forget that. I, you know, and just, I would love to say I waltzed in and did amazing and everything was perfect. And I was this fabulous nurse. I totally was not. And I remember just thinking, dear God, they're trusting people's lives in my hands. Um, I mean that, and I would go to work feeling like I was going to throw up. I would leave feeling like I was going to throw up. And there was a culture there. The hospital is no longer in existence for a variety of reasons, but there there was really a culture that permitted naughty behaviors in the from physician and just, I mean, I can't really say the whys, but I felt very vulnerable, and I had nightmares. I knew I had made the wrong profession, and there was a physician who was intimidating but also inappropriate. And you go report the behavior, and it's like, well, they bring in a lot of money, you just have to put up with it. And when that was told to me, I thought, I have to leave. And so I fulfilled my contractual 1 year and left. And I mean, I was having nightmares. I had recently gotten married and was in the car. I'd fallen asleep. I'd worked nights and fallen asleep. My husband was driving. He got out to get gas, and the door little buzzer went off, and I flipped. I thought I was trying to get to a code and couldn't get out of my chair. And I thought,
Oh my
that's
gosh.
that's when I am done. I can't do it.
It's enough.
And
Yeah, you've
yeah,
had enough. And
yeah,
I can speak because you were with me in my first year of nursing.
yeah.
And there were times, and you would come on the unit and check on us. And Sharon managed a group of nurses, and we all kind of had our units, and it was at one specific hospital, which I'm so thankful for that hospital and how great it was.
Yeah.
And I had great managers and great people. Like Timmy Trust was somebody that I absolutely trusted. But I would, maybe 3 or 4 months in, we did residency, and Sharon would come and pop up and check, and I would see her, and I'd almost get tears in my eyes because I would see you and just the kindness. And it was so hard that first year.
Mhm.
There were days I had to leave. I was sick.
Right.
How you entrusted these people high risk medications and drips and codes, and being a brand new nurse in the hospital that we were at, it was a tough hospital. It was not an
Yeah.
easy hospital.
Yeah.
I'm beyond thankful for that experience. It set
Right.
me up. But if there's any new nurses out here listening to this, and this is your first year, you are not alone. you have a
Yes.
38-year veteran and you have a 10-year veteran telling you you're very much in that feeling is it's tough. And if it was easy, if you were able to skirt
Mhm.
into work on your first year and uh, this is all easy, I'm able to handle this, it would draw some questions because you
Right.
are responsible for those people's lives. And we should have a healthy sense of caution and I hate to use
Right.
the word fear, but caution. So which is such an interesting point that you come to that you've learned a good lesson and then you moved on to a teaching role
Yeah.
and you've told me that you got your teaching wings. So tell us a little bit
Right.
about how you transitioned from that bedside role to the teaching position.
Yeah. So I left that hospital, went to another hospital in the area, and the staff, they embraced me, and they were going on a whole, like, we won't tolerate bad behaviors. So they really created a very safe environment. And I was still on night shift. It just was very much a learning. If we had downtime, the books were out, we were looking at things. So the nurses that I was blessed to work with really like challenged, what's going on, and the physicians were safe to challenge.
Mm.
I had a CNS, not I had her. We had a CNS, and and
It's
I
okay,
liked
I
to.
claim you, Sharon. I claim you. You're my Sharon.
Yeah, there we go. And I was very verbal, and I learned best by teaching. And Gail recognized that, and she was doing a skills day, and she said, "Well, I need somebody to teach the 12 lead station." And I'm like, I don't know 12 leads, but okay, I like to talk. so so she sat, she gave me a study book, and I started looking at it, and I have this ability of taking, at least in my mind, complex subjects and make them really simple. And maybe that's just how my brain works. But so I looked at the EKGs, and it's like, okay, how am I going to remember inferior? How am I going to remember this? And in all honesty, just sitting there teaching senior staff the 12 lead EKGs, and as I taught, I really started to get ownership of it, and just the support I received from the staff. And then I was given the permission to start developing content to teach. And so I would just start doing it, because if I could teach it, I could learn it. And I had some cardiologists who worked with me, who really, we'd sit down, we'd look at EKGs, or we'd look at hemodynamics, and they really taught me. And the same thing with our pulmonologists, and then of course our clinical nurse specialists. And then I took ACLS. I had taken it several times. And one time Gail tapped me, and she goes, "What about being an ACLS instructor?" And that's really where I got my practice wings for teaching, and got to learn what worked, what didn't. And so, I started teaching ACLS. And then we were part of a Seattle consortium. And then Gail was transitioning what she was doing, and or maybe it was Chris. I don't know, but they were transitioning, and they said, "Hey, why don't you teach hemodynamics pharmacology up for the Seattle consortium?" And this was the consortium that taught me back in '86. And
Full circle.
so
I love
it really
it.
was. And so I you know people were kind enough to let me practice. And like I was teaching, I had my little pointer, and I didn't realize I was blinding people with my laser, as I'm doing the slide advance. I mean, it's just like I did so many stupid things, and yet people were so gracious and give me that chance. And I think that's one of my big takeaway is you have to go into nursing with humility and humor. I mean, I don't know how else to do it.
That
It's
absolutely true. Absolutely
so,
true. I love that you say you have to go in with the humility and the humor. That oftentimes they go hand in hand for a lot of
yeah, they
the
totally do.
things that we end up doing and the mistakes that we make. And I want to. This is a great part where I want to talk about one of the greatest lessons you ever taught me. And this is a tough one. And this is something that I will carry with me forever. And for all of you listening out there, this is going to be your first
You may just,
fear.
yeah.
It is your worst fear realized. And
Mhm.
it's something that happened to Sharon, that it's our worst fear as we practice. And when she
Mhm.
told me this story, she told everybody this story, and she tells everybody in the new nursing. And I'm going to lead it in there, and she's going to tell it. And then I'm going to let you know how it has affected me and how I have carried on your words of wisdom and that experience to guide other nurses.
Hey nurses, looking for exclusive discounts? Nurse.org has you covered with deals on everything. Save big on the essentials you need to excel in your career. Don't miss out. Visit nurse.org/discounts for the latest discounts made just for you.
Fatal med errors happen. We are human, and let's
Mhm.
start this by saying that at the end of the day, we are human, and
Right.
we do not have a normal job.
Mhm.
We do not go into an office, and this is not to mean anybody in office. I do that job now. However, when we go to work, it's not that we mess up a spreadsheet and some people don't get paid. We are in charge of people's lives. In the same sense, we are human. We are just as human as everybody else, and we make mistakes, and we are entrusted with things that are so incredibly hard to deal with, including human
Mhm.
lives. And to expect us to be perfect on everything is just inhuman. And so you had an experience with a med area, and I'm going to let you take that away now.
Yeah. Yeah. This is, I've kind of tucked it far away until Jana, brought it back out. So thank you, Jana.
I'm
No,
so sorry.
this was really pivotal in my life. And I've had a few pivotal moments in nursing. This is one. I had and I'm not saying this to give excuses, it's just context. I had a friend who had just had a double mastectomy, supported her, and then went to work. They were short staffed over the weekend, so I did 16-hour shift and then came back the following day to do my next regular shift. I did 12 hours. I was actually on day shift then, that was my scheduled shift, and it was super busy. We had old pumps. They were the little dials that you had to click in, and adjust the medication rates. There was no smart errors or smart pumps. We had to do all the manual calculations and then dial it in. And then the other fun thing with this pump is that some had decimals, some did not. Okay.
Wow.
So
Wow.
I was going between room to room, and I had this gal who was she was at end of life, and I think, in some ways that gave me the ability to keep walking. I think if her story wasn't the same, I don't know if I could have kept walking, in all honesty. And I had gone in her room. My intent was to titrate down dopamine. I didn't full on look at the pump and thought I had decreased it to a rate of 9. What I had done, though, was put it to a rate of 90. And she went into VFib, and we coded her. And I was on one side. My friend was on the other side. We had stopped all the pumps because we were doing a code. And then she looks back at the pump and she asked me the question, and I about passed out right there. It's like, yeah, I did it. It was supposed to be at 9. It was supposed to be at 9.0.
Mm-hmm.
But with the pumps being different,
Right.
and again, I'm not excusing it. I look at what happened. I was tired. I was stressed. I wasn't 100% on, and I was going fast. I mean, I look at that, and that's what it was. So we stopped, and the code was called. She did not survive. She actually had a large clot in her ventricle,
Mm-hmm.
and her guardian or power of attorney wasn't able to make a yes or no decision of what to do. But what happened after, I'm so incredibly grateful for. The hospital leadership, my unit leadership, my physicians. We had the big meetings, the big quality meetings, and the ask was, would you tell your story? And the other thing I don't know what we called it then, but equivalent to a root cause analysis, we started looking at our pumps and how unsafe they were, and that it just was so unsafe. And so from that moment on, those pumps went away. We brought in one of the first smart pumps where you had to, it certainly wasn't anything that talked to a computer, but you had to go in and some of the things were pre-programmed. You'd have to select concentrations, but it built in that little bit of safety net. And there wasn't that little clicking dial. So, positive things came through that. I'd be
Absolutely.
lying to say I didn't have nightmares. I'd be lying to say I didn't know if I could go back to work, but my workplace made it safe.
Mm.
And my colleagues made it safe, and the physicians made it safe. And that was such a huge gift. And so I kept that commitment. I kept that commitment when I taught the residency, because I taught hemodynamic pharmacology up in Seattle. I taught it for the system that I worked for. And every time I taught it, I told that story. And, by the grace of God, we go every day. And I think the times when I look at even currently, when I rely on the story somebody's telling me, like, hey, yeah, blood consent signed. Okay,
Right.
I trust this person. It's like, oh shoot, where is the blood consent?
Right.
And when you're doing those double checks, when you're doing those handoffs, I would say absolutely pay attention. When you're checking TPN, when you're checking insulin. I'm now working pediatrics, so we check everything, but don't give yourself that permission to kind of zone out when you're being the double check person. And don't rely, even though it's somebody you trust, don't rely that what they're seeing is actual reality. I mean, those
Absolutely.
are my big takeaways.
I think the biggest takeaway from this is you just spoken to so many people out of this. And as a ICU ER emergency, there's not a nurse out there who has not been in that position, tired, overworked, running. Yes, we do have some things in place later on in this technology, but we have all been in your position. And
Mhm.
there are nurses out there who have made the same errors you have. And you are so lucky and so blessed that there's something that you said you had a safe, people made it safe for you. And I hope that the nurse managers and the
Mhm.
administration and the people who are responsible for the nurses who are taking patients' lives in their hand, I hope you're hearing Sharon's story. I hope that you're providing a safe place for the nurses to come and to say, I've made a mistake. I need your help. I need your help. And this is where, Sharon, we talked about this, and this is one of the greatest gifts that you gave me in nursing, and that you're giving everybody listening to you is this
Mhm.
permission to be vulnerable, because that's what nursing is. Not everybody can be vulnerable. And most of us in this profession, we're here because we are vulnerable. And
Mhm.
that's a gift. It's a gift. But I want to say that when you Google it and you look it up online, that vulnerability can be classified as the quality of being easily hurt or attacked, uncertainty, risk, and emotional exposure, and even a weak point. That's what it can be
Mhm.
defined. But Brene Brown, she's the queen of vulnerability.
Yes. I
She's
love.
fantastic. And she said something that just makes me think of you and the story that you've told. And I really hope that anybody out there who has made a med error, or I promise you, if you stay in nursing long enough, you will make a med error. It will happen to you. I want you to think that vulnerability can also mean the willingness to show emotion or to allow one's weaknesses to be seen. Brene Brown herself said that vulnerability can lead to more open communication, and that people should have the courage to say, I need help. And that's what
Mhm.
you've done, Sharon.
Yeah.
And I think that by telling your story on here and how many times you've told it, it's allowed me to be more vulnerable. I have made a nearly deadly med error myself, and I had to be responsible and own it. And it was one of the scariest moments of my life. And luckily, the person was okay, didn't suffer too much damage. But I remember in that moment when it happened, my mind went to you, and I owned it. I was vulnerable. I took responsibility, and I, at the time too, was lucky enough that it was a safe decision, and I was
Mhm.
able to overcome it with the safety. So thank you for sharing that. It gets my heart here, because to hear that so many years later there has been positive that has come out
Mhm.
of it, and people have changed, and even today people are going to hear your story, and things are going to change, and there's going to be a
Yeah.
nurse manager out there that's going to have a nurse come to her, and she's going to remember you, and she's going to give her safety. So you are making a huge change in nursing by telling that story, and I just want to thank you for that. And
Thank you.
you're welcome. So, and I want to keep going, because Sharon, I could talk to her all day, and I want to go to this, keep going. And Sharon, I want you to tell us about, first off, Sharon is very, very educated. She was also another educator. She was an adjunct professor, correct me. It was at the University of Washington in
Mhm.
Seattle, UW,
Or
and
actually, Tacoma.
Tacoma. Yes.
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 Yeah.
UW Tacoma. And she taught a clinical phenomena class.
Yeah.
And I want you to tell us what your favorite class was to teach, or your
So,
favorite topic.
yeah.
Yeah,
No,
topic.
and the class was designed by kind of my nursing hero, Sharon Gavin Fott. She developed the class. She's actually developed tons of trauma stuff. And it was where we took a look at certain human responses. And the challenge was to look at physiology and how to recognize decompensation and compensation. And then we looked at how that physiology would also tie into the experience and the behaviors that we saw. And originally, the students were writing papers, and I had so many papers to grade. I thought this is, and so I sit down with Sharon, and she's like, just how do you know that they have the concepts? And I had watched an instructor from Madigan do a concept map, and I thought, you know what, that's what I'm going to do. I'm not going to grade grammar, but they're going to do pictures. And initially, I had it as individuals doing it. I thought this is great group work. And so I pre recorded lectures and then would have the students come together, and on big old flip charts, they draw it out. And, what is my favorite? I think one of my favorite ones was when they were doing the cardiac. So they drew out, the cardiovascular pathophysiology, and then how do you know when somebody's no longer compensating? And so they'd have to describe that, what they saw physically, and then describe what it looked like when they compensated, described what it looked like when they started to decompensate. And we talked about how do you recognize when somebody's tiring, and then what sort of behaviors, that restlessness or picking at things. A lot of times they would say, well, anxiety. Well, that's an experience. What does anxiety look like? And so really diving into, so when you walk into a room, your doorway assessment, what do you see? And watching them then take that and look at the patient's positioning and all of that, and then what was the patient experiencing. And the fun part is I had people from the behavioral health, I had pediatrics, and so the different things that they brought into each group was really, really fun. And then we did like a picture show, and everybody would walk around, look at each group's art per se, and they'd have to describe what they saw. I heard again and again from students what a big impact that made. And so I think, honestly, all the phenomena were really fun. But that has been flat out my favorite class to teach in nursing.
Wow.
Um, yeah.
Sharon, and Sharon and I agreed that we were not going to script this. We had a couple topics, and we wanted to go back and forth. And that's so funny that you mentioned that, because some of the topics, I wonder, Sharon, and if you could, like you said, you can look at somebody and assess the patient, see if they're
Hmm.
decompensating.
Yeah.
In today's nursing culture and climate,
Hmm.
do you think that you, as a trained professional or somebody with experience, could walk into, say, a nursing unit, look at a nurse, look at the unit, and
Hmm.
decide if they were decompensating, if they were burnout?
Yeah. Yes. Yeah.
What would that
Absolutely.
what would that look like
So
from a nursing
I
standpoint?
So I think the importance, so you're saying if I were to walk into a unit
Yeah.
and see healthy versus unhealthy,
Yeah. What does that look like?
the thing that I would say is you're going to see something, in a sense, it's like a snap judgment. Okay. And so you always have to look at your assumptions and then validate it. So, I may see somebody who is withdrawn, and the story I may say is they're angry when they're just thinking through, okay, I've got this to do, this to do, this to do, this to do. And so I have to make sure that what I'm seeing is actually validated. So
Wow.
that, it's really easy to like there's a nurse, I love her. And actually I had a very similar nurse at another job who saved my husband's life, right? But my first off impressions were, this is a really hard person. She is hard. And the person who saved my husband's life, man, she dressed me down so many times when I was a new nurse. she
There's
totally
always
did.
one on every unit. One on every unit. Yes.
And and my story that I told myself was, ooh, this is somebody I've got to be careful around. And then, that was my perception. But then getting to know the person, it's like, oh, you have a heart of gold. You're the nurse who's going to go grab the bottle of hot sauce and bring it in to this, person who can't leave the hospital because of his chemo treatment.
Wow.
So I just want to say, can I walk in and see a dysfunctional unit? Yes, I totally can. But I also want to be careful to validate what I see.
Very wise.
And if I go into a unit and see what I would perceive as not functioning well, I'd see a lot of siloing. I would see that where people are not comfortable approaching physicians, like reporting changes because of fear of being reprimanded. People are not trusting what they see, and maybe they're not comfortable calling a rapid response because when the rapid response team arrives, instead of being supportive and curious, they're condescending. So it's that culture of not feeling safe. The other thing, so I think silence, and there used to be years ago this whole campaign on silence being deadly, and I think it still is.
If you have somebody in your life, in your nursing career, that's been a mentor, I highly encourage you to reach out to them, give them a call, send them a cup of coffee, just a text telling them thank you for everything that they have done for you. So thank you, Sharon. And
you are so worth it. Thank you, Jana. This was so much fun.
Thank you for coming on today. And thank you all for listening to this episode of Nurse Converse. And everybody, stay safe, stay vulnerable, and take care. Have a good day, guys.
Thanks for joining Nurse Converse, brought to you by Nurse.org. Help us grow by leaving a 5-star rating and review on your favorite podcast platform. Nurse.org supports nurses with career and education tips, life advice, and breaking news. Thank you for all you do and for being you.